Hello, it is now 1:32 p.m. Eastern Time. You have joined the webinar From Corrections to Community, Navigating the New Medicaid Section 1115 Demonstration Opportunity, Part 2. Welcome. We are thrilled to have you here today. I'm just going to give one more minute for everybody to get into the Zoom room, and we will get started. All right, thank you again for joining us this morning for those of us on the West Coast, this afternoon for others. We're picking up with part 2 of From Corrections to Community, Navigating the New Medicaid Section 1115 Demonstration Opportunity. Next slide, please. I'm thrilled to, my name is Hallie Fader-Tao. I am serving as the interim director for the behavioral health team at the Council of State Governments Justice Center, which is, I will be moderating today's webinar, which is hosted by the U.S. Department of Justice, Office of Justice Programs, Bureau of Justice Assistance, as part of training and technical assistance available through the Second Chance Act. It is my pleasure to have with us today Meg Chapman, a policy advisor from BJA, Commissioner Helen Hanks from the New Hampshire Department of Corrections, Medicaid Director Henry Littman from the New Hampshire Department of Health and Human Services, Deputy Assistant Secretary for Health Services Ronna Cole from Washington State Department of Corrections, and Assistant Director Jason McGill from Washington State Healthcare Authority. To give you a sense of today's agenda, first, we are going to have a quick overview of the Office of Justice Programs in BJA. Next, we will hear from the corrections and state Medicaid authorities from 2 states that are pursuing 1115 waivers, New Hampshire and Washington. We'll have a chance to hear from each of those states about what they're doing, and then we'll have a panel discussion to get a sense of how they got started, the process for developing their Medicaid waivers, applications, and what they've learned. We have reserved time at the end for question and answer, as well as a set of resources for those of you looking to do this work in your own communities. Just before we get started, some housekeeping items. At any time during the webinar, you can ask a question by clicking on the Q&A button at the bottom of the screen and entering your question. This would cover both technical and content-related questions. We will try to reply to the technical questions in the chat as we go. For the content-related questions, we have one of our team members who's keeping a running list, and we'll be working on ensuring that they make their way into the Q&A session at the end. We'll do our best to get to as many of the questions as possible, and we also hold on to the questions that we aren't able to answer to inform future resources and technical assistance. If you encounter technical issues during the webinar and are unable to access the links available in the chat, please email BJAN as in Nancy, TTAC as in chorus at usdoj.gov. The webinar is being recorded and will be available on our website in the next 2 weeks. All right, it is my pleasure to turn it over to our host at BJA, Meg Chapman.
Thank you, Hallie. As mentioned, yes, I am Meg Chapman, and I'm a policy advisor at the Bureau of Justice Assistance. We are so happy to welcome such a diverse group from so many states all over the country for the second webinar in our series on the opportunity to improve community reentry transitions through the Medicaid Section 1115 reentry demonstration opportunity. The Bureau of Justice Assistance is located within the Department of Justice's Office of Justice Programs, or OJP. OJP is DOJ's largest grant-making organization, providing a wide range of services to the criminal justice community in the form of grants, training, technical assistance, and research. Next slide, please. So the Bureau of Justice Assistance's mission is to provide leadership and services in grant administration and criminal justice policy development to support state, local, and tribal justice strategies to achieve safer communities. BJA works with communities, governments, and nonprofit organizations to reduce crime, recidivism, and unnecessary confinement and promote a safe and fair criminal justice system. And our director is Carlton Moore, who was appointed by President Biden in February 2022. BJA's programmatic and policy efforts provide a wide range of funding and resources, including training and technical assistance to law enforcement, courts, corrections, treatment, reentry, justice information sharing, and community-based partners to address chronic and emerging criminal justice challenges nationwide. At BJA and OJP, we work alongside many federal partner agencies in order to serve the American people. We've worked together to better understand the challenges facing people returning from incarceration and how we as federal partners can work together to help ease those challenges. Health coverage has been one of these areas. We have worked together to understand from corrections administrators and staff, as well as people returning home and their loved ones, what stands in the way of accessing healthcare, including behavioral healthcare. So today's webinar is really exciting to share. And as we mentioned, it's part of a series of work we are doing focused on this issue. And we're so pleased to be able to discuss the new Medicaid 1115 reentry demonstration opportunity with representatives from 2 states. I'm going to turn things back to Hallie, who will give us an overview of the program on today's webinar.
Okay, thanks, Meg. As we mentioned, today's webinar is the second in a series focused on the Medicaid reentry demonstration opportunity. In today's webinar, we're hoping that by the end, you will leave with some insights into the processes and stakeholders that Washington and New Hampshire have brought together to develop and plan and implement the Medicaid Section 1115 reentry demonstrations. You'll also hear firsthand about opportunities for corrections agencies in scoping, planning, and implementing the demonstration waivers. We really encourage you to listen for the concrete activities and steps these states used to build their partnerships, to think about how to scope these waivers and implementation considerations. And while we're here today to focus on the demonstration waivers, I know these speakers are also going to cover a lot that's relevant for building these partnerships more generally towards that shared goal of helping people get moving from corrections into care in the community. Next slide, please. If you weren't able to join us in our first webinar, which was really the introduction, I'll give a quick recap now, and we'll also be providing links so you can see that recording and the relevant resources. In July, we had covered some basics about Medicaid and the Section 1115 demonstrations, including the content from the state Medicaid director letter that came out this April from CMS. That letter includes some really helpful information on the rationale for the waiver in terms of the relationship between health coverage and criminal justice system involvement. The webinar also discussed opportunities for corrections leaders to support pre-release services in correctional facilities, and discuss potential benefits from the demonstration opportunity, including improved health and justice system outcomes for people who are returning to the community. It is very important to us and to BJA to understand how we can be of greatest service to the field in helping you understand these opportunities and bring them to your states and your communities. So we'd like to have you take a moment to fill in the poll that's about to come up. So we have a sense of who's here today. That will also help our presenters tailor their comments. So if you can just take a moment, pick the circle that best describes your role, and then I'll thank our hosts at NTAC for putting the results up for us. Thank you. So we have a real mix here with us today. Thrilled to see a good chunk of people who are here from state corrections leadership, as well as from state Medicaid agencies, also from local corrections, and that's one of the angles we're going to be talking about today, as well as community providers. Be interested to see who the other folks are. Okay, one additional question. If we just wanted to get a sense of how many people are coming to us today, having attended that first webinar in July. So you're not in trouble if you weren't there. It just helps us get a sense of who the audience is. If you can just let us know quickly, were you here in July, or did you watch the webinar on recording, or are you coming to us fresh today? Thank you, super helpful. All righty, before we get into the stories from Washington and New Hampshire, we wanted to provide a little bit of a national landscape so that folks have a sense of the activity around the country following or alongside the release of the state Medicaid director letter this April. And if I can get the next slide, please. So you can see here, these are the states that have applied for and received approvals from CMS for their demonstration waivers. So California and our friends here today from Washington have received approvals, and then there are 14 additional states, including our friends from New Hampshire, who have already submitted proposals. All righty, I'd like to turn to our panelists now and welcome Commissioner Hanks from the New Hampshire Department of Corrections and Mr. Littman who's the Medicaid Director for New Hampshire Health and Human Services. Thank you for being here today to join us. We would love to hear from you about New Hampshire's story. Can you give us a sense of how you got started thinking about a reentry demonstration waiver? Why did it make sense in your state? And what's the scope of what you have included?
Well, good day to everybody, because I know we're talking across time zones here. So New Hampshire saw that it needed to strengthen its community-based services for substance use disorder and for mental illness. CMS, Centers for Medicaid Medicare Services, had provided 1115 opportunities in substance use disorder and mental illness to be able to, for states to be able to make additional investments in the community-based setting, while at the same time providing states additional coverage of reimbursement in areas where it previously hadn't. And so that was in the inpatient setting. And so the expectation is that in exchange for the additional funds that are being provided in the inpatient setting, that the state would redirect those monies to strengthen its community-based system, whether it be substance use disorder, mental illness. We received our original substance use disorder 1115 waiver in 2018. In 2022, we added the mental illness component and made application before actually the state Medicaid director letter was out to be able to do community reentry. And sort of the history of how that sort of came to pass was the work I think that we had done with Commissioner Hanks in the Department of Corrections in New Hampshire, working with the Medicaid expansion population, making sure that that when they left the correction system, that they didn't have an application, a Medicaid application that was turned off, but actually one that was suspended, which would be easier to get them enrolled so that when they left the correction system, they'd be more successful. Also participating on a governor's commission with the commissioner and other leaders in the state in all different areas, looked at, the major reasons for reincarceration and so forth. And I think Commissioner Hanks can probably speak to what led her to be interested in this, but I think we could see the same thing, that substance use disorder and mental illness was a major factor, not just for the population at large, but also for the correctional situation. I don't know if that covers it enough for you, Haley, but I think that gives people a brief overview.
So if I could add, in addition to the work that Henry talked about here in New Hampshire, we have a governor's commission on alcohol and other drugs, and we're fortunate that brings myself and people like Director Littman to the table with legislators, community providers, businesses, and the conversation has helped us move from places we were a decade ago, moving from termination to suspension. In corrections, we talk about all of the things we do to invest in a person's wellness, and then we talk about their benefits cliff, because we know that our healthcare access as individuals is dependent on our ability to pay and our insurer. And in New Hampshire, until we adopted Medicaid expansion, there was no clear path for that continuation. And I don't want to lose sight as we talk about where we are now with the 1115 waiver across the nation. But back in 2016, the Center for Medicare and Medicaid Services sent out a very important clarification that talked about transitional housing, and that if people's access to the community were at a certain extent, then really that application to Medicaid could happen. And people who were eligible for Medicaid could use that benefit, even if they were living in a corrections managed transitional housing unit. And so these key points across the continuum of the timeline have brought us here today. And to Henry's fine point, and I feel like I've really imparted a lot of my partner over at Medicaid, yes, mental illness, inclusive of substance use disorder, is that cyclical pattern that results in reincarceration. And here's just another great opportunity to bring our community mental health centers, our substance use treatment providers into the equation prior to release, to really strengthen that reconnectivity to community and help people have the best chance of success.
The externalities that exist beyond Medicaid and beyond corrections in terms of people successfully integrating back into their community and being part of the workforce, given the workforce shortage, is another element that I think comes out of this. And when states are looking at this, it's, try not to look at it in a narrow fashion, but in the broadest fashion possible. Thank you.
No, I really appreciate how you both sort of created that history of different ways that you've partnered and different strategies you've used over time to think about how to get care for this population. As you've been thinking about this specific opportunity, what's the scope of what your proposal includes? Who are the populations covered, the facilities, what sort of in-reach planning are you contemplating? And so I guess two questions. One is, what did you include? And two is, how did you get there?
So it might be helpful, maybe Commissioner Hanks, to begin with kind of what is happening in state correctional facilities. And New Hampshire chose to start in one place and then look to work out into the jail community, what is a county-based system in New Hampshire.
Yeah, thank you for that. And so in New Hampshire, it's important to state we're not a unified system. The county jails are distinct independent county jails from each other. They have an association, but they're managed by one county at a time. State corrections is separate. In state corrections in New Hampshire, it includes probation and parole services. So I have really the benefit as the commissioner to have that pre-incarcerated hopeful opportunity, incarceration, and then parole in my continuum of responsibility. So what we did is really narrowed in on what we're doing in corrections really well and how can we be a good partner, because what we ultimately want to do is have a demonstration that results in success. We don't want to not have more support as we've traveled down the road. And we have robust case management services. We work on reentry at the time of booking, and we look at I'll call it the whole person, their education, their mental health, their job skill, vocational skill. We connect them with a driver's license or a state identification card if they don't have the privilege to drive before they release, and all of those things, and housing and elements. And I will pitch in New Hampshire, we on the same governor's commission, it's an opportunity where I partnered with the judiciary to create a housing program for people leaving correctional settings that is managed between the judiciary as the primary, but we're the beneficiary of that resource, and that matters. And we know that as individuals, but we also know that in corrections. So mapping through that, we started doing medication for the treatment of opioid use disorder back in 2010 and 2011. So we know that that intervention is purposeful and helpful in helping people find recovery and reduce their relapse futures. So we said to ourselves, what's missing and what do we want to strengthen? So what was missing for us in New Hampshire is building our peer recovery contact supports. I purposely asked Director Lippman Henry if how could we build this into this waiver? And also what's also missing is reach in. We don't want people meeting their primary care providers, whether it's their primary medical provider or their primary psychiatric provider post-release, because as individuals, when we meet that person and we get to know them, when we start to form those therapeutic bonds, we are very much more likely to go to our next second appointment and third appointment, and so on and so forth. So how do we maximize pre-release contact? And then also making sure that the continuity of pharmaceuticals that we're prescribing for people continues. So we partnered in three key areas: provider appointments and having those contacts prior to release, peer recovery support contacts, and continuation of people's pharmaceuticals, as well as leveraging our strengths around treatment interventions for substance use disorder and mental health as a broad statement, integrated statement, and also our strong case management services. Henry, what would you add to that?
So integrated into that is how they make the transition from Medicaid eligibility to be actually in Medicaid. So what we want to do is before they leave corrections is that they're enrolled in a managed care plan, that managed care plan is coordinating with the Department of Corrections folks to make them plugged into the system outside of the correction system, so that when they go out the front door, they're not beginning to look for, example, an MAT provider. They're not looking to make those initial connections, that they have a chance of, they're going to have the medicines they need leaving out the door, but they're also going to be all set to be able to continue on. So there's a transition, just like if you're coming into a new job, that getting all set up and situated. We picked a 45-day reentry period so that we could spend about a week or two sort of getting them situated, and then about a month to be able to get those initial appointments, whether they be through telemedicine or what have you. We purposefully kept it sort of narrow. We're not a big state, and thinking about how we're going to work out beyond the correction system to the jail system, that we want to have something that's reasonably easy to stand up and is really hitting on the high points of where the correction system is seeing the issues today, and that we can take the extra additional funds that will come from CMS to strengthen the system. For example, housing, we have a housing waiver under Medicaid that's separate from this waiver, where we could help additionally support what's people leaving who need, because if you don't have a home, it's hard to have health. And that's, I think, something that is recognized in the state, and, you know, trying to also look at the opportunities for reemployment, which is another success factor that, you know, having in New Hampshire, we now have an adult dental benefit, having a healthy mouth is part of being, you know, able to survive and have a, you know, a productive life outside of corrections. So I don't know if you'd add anything additional, Commissioner.
Further, just to state on the case management side, we really tapped into pre-Medicaid expansion. What could you do in corrections? And so most corrections leaders know there's the opportunity for an inpatient eligible stay to be referred and deferred to Medicaid. And so again, talking about having a strong relationship in your state with your Medicaid director. If you don't have one, make one, get one. They need to understand, and they're looking for that type of opportunity. But the reason I went back that far is because here we are now with this opportunity, and our experience is enroll people in Medicaid. So you're not enrolling them on the last day you have them, and their benefit is not a benefit until 30, 40 days after release. And so this takes the work we've done to resolve that and continues to build on those different building blocks of reintegrating people back into their communities.
Some of the new funds are generated by the fact that rather than the correction system having to bear the burden of cost all the way up to the day they leave, is that within that 45-day period that Medicaid in a new way can pick up some of those costs, which then create the reinvestment opportunities. And that's, I think, one of the key features here. And I think over time, we can look at, you know, once we have built a sort of a successful model that can be done both in corrections and in jails, is also looking at what other benefits might be useful to add to this. Because at the end of the day, states have to prove under an 1115 waiver that it's cost effective. And so, you know, in terms of this situation for any state, that it's not that the federal government's willing to pass on money with no strings attached. You have to reinvest it, and you have to show actually through an independent evaluation that what you're doing is effective.
Well, thank you both so much. This has been a really helpful introduction to the work in New Hampshire. Amy has put in a chat a link to the application, folks, and we'll send it out as well afterwards. But if you want to see the details behind what they've just been talking about, and we're going to come back to Team New Hampshire in a little while, but for now we're going to hop in the airplane and head west to talk with Jason McGill and Ronna Cole from Washington State. So Ronna, Jason, same question. Can you talk a little bit about the history that got you to this point, as well as what you're hoping to do? Well, now that you've gotten your approval, what you're hoping to do with your waiver?
Thank you, Haley. Yes, hello, everybody. Thank you, Henry and Helen. Great summary. So we'll talk a little bit about Washington State. So good to be with you. And my friend and colleague in our Department of Corrections, Ronna Cole. We have some history in Washington. So we'll talk about the waiver, but I think our takeaway in addition to that today is our partnership and the history we have, the strong partnership, collaboration from our legislature, our governor, and our cabinet, particularly in the corrections prison side, to really build the waiver. We did obtain the second in nation waiver, and we are underway in terms of our planning to implement, but it's going to be a long road. However, we need to start somewhere. And Helen and Henry talked a little bit about what New Hampshire's doing, similar in Washington. We've had strong eligibility and what we call in Medicaid suspension policy. In other words, if you enter into jail, if you enter into prison, and you're already on Medicaid, we're not going to terminate your coverage. We're going to just suspend it. So when you get out on reentry, it's an easier turn back on full coverage and without further delay. And so that's a pretty critical piece, that a suspension policy. And that is a requirement under the waiver. But before I get too much into the waiver, I'd love to turn to my colleague, Ronna Cole, for some of the great examples of our history and partnership working together. And then I'll talk a little bit more about the waiver and detail that out for you all in what we're doing in Washington. Ronna?
Good morning. Thank you, Jason. Good morning from the West Coast, and sharing absolutely that as the previous panel shared, that communication or that collaboration, that partnership is just key and vital to the success that we've experienced in Washington State. And so as Jason shared, we have a history that goes back to about 2011, where we had a perfect storm. We were in the throes of the recession in our state. So money, and as we know, especially with corrections money, it's not sexy. It's not easily to attain. And so really some outside of the box thinking as to what Washington State could do to enhance healthcare for our incarcerated population. We had three key players. Actually, she is our current secretary today, but at the time was the deputy secretary here with the Department of Corrections. And we had two individuals that had come to us from Jason's area today, but had come over to Washington State Department of Corrections and worked as our budget lead and as a healthcare administrator in DOC. And their minds got together quickly and realized there was some huge benefits that we could see. Washington State was being plagued at that time with people not seeing our incarcerated population in the community. Again, money a big issue. So we came together, had legislation passed that allows the Department of Corrections and requires hospitals in the state of Washington as a condition of licensure to accept all of our medical bill payments through the state's Provider One Medicaid system. From there, we have a team here in Washington, Department of Corrections, that adjudicates those bills. So like was discussed earlier, if that person is a qualified inpatient event, it goes through and it is paid through the Medicaid bill payment system. The remainder of them are adjudicated through our state system. And to build in that collaboration, that was huge. That started the partnership that continues to roll for the state of Washington. It's improved our staff safety, it's improved recidivism, and it's helped us to leverage that Medicaid funding. In addition to that, much like Commissioner shared in New Hampshire, we have a very robust reentry system in the state of Washington. And as part of that, our healthcare has a robust reentry system. And so we're already partnering on many avenues where we meet with our state partners in the healthcare authority, our social services, in a reentry forum or in a reentry group. And that history of bringing justice involved entities to the table, our juvenile systems, our jails, much like New Hampshire, we are just like New Hampshire. Each of our counties have independently ran jail systems, and then bringing the Department of Corrections into the room to talk about our justice involved population from a reentry perspective. That's been very successful in helping to understand pathways that ultimately resulted in our waiver and our success with the waiver. We in Washington State, as Jason shared, have had that suspension in place since before 2016. So again, an early adopter of working with our Medicaid partners for that suspension, but it has been a huge piece for us that we have actually integrated into our state correctional databases that independent Medicaid number in Washington State, so that our staff in the Department of Corrections, our community staff in the Department of Corrections has access to that number so that we can help our justice involved individuals as they re-enter into the community, ensure that they have that information at their fingertips. And then one other unique piece for Washington is that we have a process called Swift and Certain, which brings justice-involved people back due to a violation for up to a 15-day stay in either a jail in the state of Washington or into the Department of Corrections. So that collaboration between, again, the jail partnerships, the Department of Corrections, and our healthcare authority to be turning on and off that Medicaid and ensure that that reentry after that 15-day time has been very successful in ensuring that justice-involved people have their Medicaid coverage. Jason,
That's great. I think that's wonderful. I might talk a little bit about the waiver now and where we're heading to next, because again, Rod, I think you did just a great job sort of confirming, let's start with a strong partnership, and that work, as you can imagine, takes some effort to just begin. And we've got a lot of that underway in Washington, so we're very fortunate. We have a legislature supportive, and so they have passed legislation really directing us, and our governor, dating back to opioid epidemic work, now nearly 10 years ago, introducing the concept of a waiver for, in the very least, medication for opioid use disorder while in a carceral setting. That was the first sort of inquiry to the feds about doing something along these lines. But very quickly after, bipartisan legislation on the congressional level passed, and that was the Support Act for opioid epidemic related work, as many of you probably remember. Part of that, though, was an instruction to the federal agency, our Health and Human Service Agency, and our Centers for Medicare and Medicaid Services agencies, part of our federal HHS agency, asking them, how can we use Medicaid in carceral settings? And again, particularly with the focus on behavioral health, particularly medication for opioid use disorder. Since then, as Haley and others have, you have your first webinar dived into that 1115 detail. I might mention, what is 1115? 1115 is simply the United States Code for Medicaid that gives some flexibility to states, in which the Secretary of HHS and the CMS director can waive certain provisions of otherwise Medicaid law, so states can demonstrate, and states can have a flexible program. So that's why we call it 1115 waiver. So we now have that. It is for a limited benefit. We're not talking the entire Medicaid benefit. As I mentioned, it's sort of stemming from the Support Act. So we're focused with behavioral health. So the mandatory benefit is very clearly medication for assisted treatment, and that is more broadly than medication for opioid use disorder, but absolutely includes MOUD treatment in a carceral setting. It also includes care management and pre-release and leading to post-release care coordination. That is absolutely mandatory. In other words, you can't start something pre-release unless you have a plan post-release. And that's just not a plan, that's actually a referral. You need to have a real referral to a pharmacy for your medication, a real referral to a primary care or behavioral health specialist. And so that creates, we need a system that works, that communicates from pre-release and post-release. In addition, a post-release requirement here. So in other words, before getting anything pre-release in an carceral setting, CMS requires that we have a system built where upon release, you get 30 days supply of your medication. This is not just a script in hand, a prescription in hand. This is the actual medication in hand upon release, which is something Medicaid already covers today. But under this waiver, that is a post-release requirement to get pre-release services. In addition, so those are the mandatory pre-release services. In addition, the CMS allows states to also pursue other post-release and pre-release services, such as the full pharmacy benefit. not just behavioral health, not just MOUD or MAT services, but the entire pharmacy benefit. It must be the Medicaid formulary. So that is a complexity. But if you're already, for example, using a pharmacy contractor to help, you could probably not going to be too complex to use the Medicaid formulary. That is important because on the federal level, there's Medicaid supplementary rebates associated with pharmaceutical drugs. So there's a major financial impact, and federal law simply requires it. So there's no flexibility there that the federal level is allowed to provide. But it's a huge benefit. About 25% of total healthcare spend is pharmacy spend. So that's the big one. In addition to, as I said, MAT treatment and MOUD treatment and care coordination treatment, we also are allowed to use targeted behavioral health screening and targeted treatment, lab and radiology, Hep C screening, for example. So Hep C's clearly, if you take up the pharmacy benefit, you need to have some evaluation screening, some lab and radiology. And we can include all of that in terms of pre-release. So let me pause there. Oh, two more things. Sorry, Haley. 90 days pre-release, minimum 30 and up to 90. So states have a choice there to work with CMS and on the federal level, and we're taking 90. Our legislature directed us to do that. And capacity funding, implementation. This is not going to be easy, and we know that. We know that there's a lot of requirements. I mentioned the pre-release and post-release communication and referral care management wise. This is hard. Not to mention billing. How do you bill for these services in jail? Yeah, you could hire a contractor to do that work and help with that. Or you can do this in-house. You can have a in-house physician, in-house provider, and bill. If they're credentialed, by the way, which is another requirement, you have to have licensing, provider credentialing, and billing. So there's capacity funding as part of our waiver we've created to help fund some of this work and to help our local jails and our prison system, our Department of Corrections, our partners with RANA DOC to help support that. I'll also mention our juvenile rehabilitative state agency is in the mix here. That's not necessarily waiver services, that's under federal law, and our local juvenile detention run by, in Washington, run by our courts separately. And one last thing on my notes here, Haley, is just a thank you to our Washington Association of Sheriff and Police Chiefs. Been a huge partner in working this, certainly this waiver work through, but in addition, we work with them today and have for the last few years on figuring out where people are at in local and carceral settings. So we have a daily download feed that we work into our Medicaid system and that our Washington State Association of Police Chiefs, Sheriffs and Police Chiefs manage for us via contract. And so we're building off of that strong partnership again. So our theme of partnership and collaboration is strong in Washington. I'll stop there, Haley. Anything else, Rana, that you would cover?
No, I would say that the streamlining of bringing our jails in was really instrumental in that suspension. So our jails have that automatic removal of suspension, just like the state does, and that has been very instrumental moving forward.
No, thank you both. I'm going to ask our friends at, so thank you. I'm going to ask our friends at NTAC to take the slides down and bring our panelists back up for some questions. And I actually wanted to build on what Jason just said about who is at the table. So this question is for Henry and Jason, but obviously for others too. I'm using the panelists' first names with their permission. It felt like it would take a long time with all of the titles. But for Henry and Jason, I'd love to hear the two of you talking from your perspective about how you determine the scope, the factors you considered, and sort of to Jason's point, who is at the table. I mean, I can imagine you're thinking about health across your states. How did corrections become how did you start thinking about corrections? And then who is at the table? How did you start to focus?
Henry, do you want to start or do you want me to start in?
Why don't you go first, Jason, this time?
Okay, thanks, Henry. I'll just mention a couple of things, Haley, to that. One, our legislature was very helpful to say, hey, let's have a statutory committee. Let's give you some instruction, Medicaid agency to work. So we have what we affectionately call our RAW committee, our Reentry Advisory Work Group. And so we've started that work. And again, building off of all this work Rana and I mentioned. And so I think that's important. I think you've got some good legislative direction, good direction from the governor. So starting there. And then clearly we have detail from our federal partners. So you might think we can just get together and just really form whatever we want to ask the feds. No, the feds have a framework here, folks. There's not a lot of flexibility. And as much as we'd like to come up with our own state system, and it is possible, you can certainly request different waivers, but if you want something that is efficient for the federal government to authorize, you have to work within their framework. And so in Washington, we decided to just simply do that and not get too much more fancy than that, because we knew that we would go from the top of the list in terms of waiver approval to the bottom of the list. And a waiver approval takes all of federal government. There are multiple agency approvals, and it is not easy to ask for those waivers. So my 2 cents on this is to stick with the framework. And if you do that, they will prioritize and get that waiver approved faster than if you do not stick with the framework. And Haley, I think that's an important comment, because I remember our conversation, Rana, when we were sort of discussing, well, should we have worked more on this waiver together? And I simply said, no, because we don't have a lot of flexibility. We just need to get that waiver through, and then we need to work on it together in terms of implementing it well.
So I think just to maybe fill in some complementary spaces to what Jason was speaking to, and working sort of backwards in terms of submitting a waiver request. There's a process of public engagement that has to happen. And so Medicaid programs are required to have what they call a medical care advisory committee, which is a broad range of folks. Our committee is well over 30 individuals representing like legal assistance, the disability rights, and all sorts of providers and individual beneficiaries. And so before we can actually submit what we're going to do, we have to submit it for public comment. And then there's also a national public comment period. And so those things happen. But to get to the point of putting something together to put in front of the public, in part, I think we talked about earlier how I think corrections and the department and to a certain extent with jails in the state worked on getting people suspended versus closed in Medicaid, and also in some other areas. But I think that in our state, the way the process played out was our governor was a leader in terms of sort of giving us the authority to kind of work interagency to develop this. The legislature was involved in terms of had an approval process in the original base waiver to okay us applying for it. And then the process has kind of worked from there. But I think there's been significant engagement all over our unified Department of Health and Human Services, all the different areas like the areas of substance use disorder and mental health, but also, across various state agencies and the governor's commission on mental health and the correction system was a good table for us to be at as well in terms of the types of issues that we identified there and how the waiver could support some of those challenges. And I'll pass over to Helen to see if she wants to add to that.
I think the other really important stakeholders we talked about, the people at the table, are the providers themselves, and I mean that in a really broad sense, including peer recovery support organizations, and understanding that people who have the experience of being incarcerated are part of that network of support services, and that as corrections leaders, we have advanced our thinking over the decade and recognize that this reach-in type of activity is absolutely integral to the success of people who are exiting correctional facilities, and having a supportive person who understands the experiences you've had and is in a healthy direction. So we talk about all those groups. It takes an actual whole village, and our legislature to support that. And then looking at those nuances, someone asked a question about how are you going to provide access to providers to your facility, and we really had to provide broaden our laws around telehealth in our state to be prepared for even remitting our waiver, recognizing that our partners in our communities that are providing different services are experiencing staffing deficits, but want to be a partner in these waivers. So creating a efficient pathway to that type of encounter was really important. So I just didn't want to lose sight of that in this conversation. You do have to look at your state laws and make sure they're ready for you to do this.
And I'm sorry if I could just add one thing there to the Medicaid as a program has, among the different federal programs, the broadest opportunity for states to elect for telehealth to be a tool in the delivery of services. I'm sorry if I jumped on your.
No, that's fine. And I was just wanting to add to what Helen had shared. And it's having that open and honest communication at the local level. Many people, although they don't want to say it, they're dealing with our justice involved population every single day in the services that they're providing. And it's bringing them to the table and having these conversations so that that process is much more engaging. That has been a key component, I think, as part of this waiver, is getting everyone to the table.
Ellen, if I can pick up on something you said earlier, and this question's going to come to you, Rana, as well, in terms of the difference between state corrections and locally run jails. How did you think about those very different types of facilities in the design for your waiver?
Well, thank you for that question. We did make a mindful decision to start in New Hampshire with state corrections. Again, we're not a unified system. So I'm the commissioner of state corrections. I run state prisons, probation, and parole. I do not oversee our county jails. They're well supervised by individual superintendents, but each one has a different infrastructure and preparedness. So I'm working with Henry. Our goal is to show and demonstrate success, and then work with our partners and do lessons learned and remit another waiver and then incorporate our jails. And one piece we're not talking about because it's not included in our waiver is also the juvenile justice system. And I know other states have incorporated that population within their waiver, and those young people are absolutely, again, another valuable area for each state to evaluate, again, your preparedness to demonstrate this success, because we all want success. We want CMS to see our success, the reinvestment, the engagement, the health and wellness of people in our states and those benefits. And it was really a mindful decision we made here in New Hampshire to know what we can do and do it well, and then advance in the future. And I'm very honored to hear about every other state that has a wider scope of effort, and excited to see how they do it. So I can learn from that in our future here in New Hampshire.
Helen, I might just mention, Haley. Oh, please, Rana.
Oh, I was going to share that our structure in Washington State is identical to New Hampshire. So what Commissioner shared is exactly going to be the experience we're going to go through. We have this one unique law in the state of Washington that I shared earlier, swift and certain, which does bring us closer together with our jail partners in that we have justice involved individuals who today might be housed in a county jail, tomorrow might be housed in the Department of Corrections for very short durations of time. And so our hope through this waiver is it is going to bring it into one justice involved process so that we're better linked with our county jails through this waiver. And we've had early conversations with the healthcare authority, with Jason and team, to help us unite that front through this process.
That's right. I just love that conversation. Helen, thank you, and Rana for really calling that out. I think it is an important. We are doing a similar, I mean, it is different. We are doing a phase in. We are doing twofold. One, I mentioned the mandatory benefits versus the secondary or the other benefits, full pharmacy versus MAT, for example. So we can phase that in. And Helen, just like I think New Hampshire, as you mentioned, obviously I'm here with my friend at our prison system. We think prisons can start sooner than most of our jails, but we do think we have some very strong relationships with many of our local jails. So we decided to try it. And we have what we believe, and we're still working out details. So please, folks, we're working out our implementation plan now, but we'd like to have our first set, I'll call it our cohort, whether it's prisons plus a few jails, start July 2025. And we'd like to back up from there about a 12-month window where we can get capacity grants out to locals who are interested and demonstrate some modicum of we're ready. We're going to be ready in 12 months to meet that July. And then great, that's our first cohort. And then maybe every 6 months after, have a re-review for others who, other jails, maybe there are prison sites, Rana, we haven't got into this level of detail, but maybe there are prison sites ready versus others who are perhaps not as ready, that may come on as the next cohort in the next 6 months. And sort of, we're thinking about it in that way. So again, twofold: one, timing wise, that the facility can choose, and two, maybe they can start with just the mandatory set of services and then roll in the secondary set of services in the future when they believe they are more ready for that. But again, not precluding an earlier readiness, at least for the mandatory set of services. So that's how we're sort of dealing with some of the phasing and prioritizing the population and trying to do what we can in a reasonable, realistic implementation.
Thank you all. I'm going to have another question or two for the panel, and then going to be going into answering the audience Q&A. So just wanted to give some thinking time for those of you who've been listening. If you have questions for the panelists, to put those into the Q&A area. It looks like a little conversation bubble and says Q&A at the bottom, and we'll be trying to route those as quickly as possible. I guess one question that we had was what was it like working with CMS through this process? Do you have any recommendations or experiences to share in terms of the conversations and what that process looked like? And maybe I'll start with the Washington team.
Well, I think one, our colleagues at CMS are just wonderful. As I mentioned earlier, as I sort of intimated, it is not easy to push these waivers through. So it is serious, serious work. All of government work, to some extent, the federal level, White House on down, really is involved, as I understand it from some of our CMS colleagues. So real empathy to their capacity, resource, and prioritization. That's why the framework is so important. That's why we decided pretty early on, this is going to be hard for you to do anything different than what you've already issued in California, what you've already issued in your state Medicaid director letter, So we asked the administrator, Dan Sy, Dr. Sy is a former Medicaid director, and so a good colleague of ours who understands the system well. And we asked him, is there any flexibility here in terms of, say, phasing, in terms of, say, trying to find ways to give some flexibility, certainly understanding the framework design, not asking for any flexibility on the benefit design, because that's a whole different question. But can we phase that? And that's, as I mentioned earlier, that's where we ended up with them. And it did take some significant back and forth to sort of figure out what the possibility is there. But again, we did not, change the benefit design. We did not change the sort of minimal requirements listed in the state Medicaid director letter. But Washington's a different system than California. California had a state law on the books that told each and every jail and prison facility, you have no choice. You have to comply and participate. Well, Washington doesn't have that law, and I'm not certain it would be entirely realistic, even if we did have that law, to expect everybody would be ready at a certain period of time. So that's why we chose to look into that phasing. And again, the team was wonderful. I think it takes, where are you in your state on the list of sort of prioritization? And then as soon as CMS is able to prioritize that state, you're like in a hopper, in a list, at a prioritization. And then CMS, the team will wrap supports and dedicates a weekly, at the end, their daily meetings to get this work done. And they did, and they are wonderful.
That's great. I'm going to see if any of the other panelists have thoughts on that, but I'm going to do it under the umbrella question of, from your experience so far, what advice do you have for others? And perhaps we can just go around with each of you providing a couple of thoughts and reflections. Rana, can I start with you?
Sure, and I think that actually I'm going to steal Helen's thunder probably. It's that relationship with your Medicaid director in your state. That first and foremost is to develop that relationship between the state correctional entities and your state Medicaid. Once you two start to develop that relationship and bring your staff in, that to me is where the building blocks start that then get us down the path. So being that step one, and then the community partners, of course, external from the state agencies, but getting all partners to the table eventually to bring together that knowledge base, eliminate some of the fear, because people get fearful of our population, and bring forth just the knowledge of what we're doing as a state entity for our reentry services. Those to me are the two collaborative pieces that need to step up first and foremost, is developing the relationships.
Yeah. And I wouldn't say you stole my thunder. I echo that, but I did want to say, because we haven't talked about it yet, part of being prepared to do this as a correctional partner with your Medicaid partner is having and people have asked, the IT and information infrastructure to know where you've been, where you are, and how to monitor and report this back to CMS. And it's not a judgment. You just have to know if you're ready. And I do want to be careful. I think in New Hampshire, many of my colleagues that are jail superintendents, some of them are ready, but we did make a conscientious choice just to start in this sort of, I'll call it narrow scope, and then move forward. But that data sharing agreement that we've had as a partner in DOC here in New Hampshire with our Health and Human Services partner did allow us to understand we had some stumbling blocks years ago that we've overcome, and we have some work to do moving forward. But when I think about, I heard our team at Washington present that you had a paper record and we had an electronic health record. I went, whew, That's not one thing I have to worry about. And so I'm not sharing this to scare anyone away from reporting, but just make sure you know what you can do, what those barriers are, and have a plan to overcome them, because the value to the people affected by this opportunity is more important. And we need to get to that outcome.
I guess building off what you were saying, Helen, was, having the information about the experience of recidivism and the types of conditions that were associated with that. We began a dialogue with CMS well before the guidance was published, and we tried to think about, where could we have the most leverage for the least investment, if you will, and try to not over ask, if you will, to CMS. Ultimately, one could look at New Hampshire and say, maybe you under ask, but I think the reality of these waivers is that states are going to be held to a budget neutrality concept. And if you don't meet those budget neutrality concepts, there's potential of having to make repayments. So what we're trying to do is have the biggest impact with the smallest footprint. And then once we have the success, build up from there. But I think in the interactions with CMS, we had a good case story to relay and to give it time to breathe with CMS and developing to your relationship with the folks that you're going to be interacting with. And I think also part of the success at a state level with CMS is sort of your track record in interacting with them, as well as in anything. Those things matter too.
That's right, Henry. And really, it was just also reflecting Roger's question in the chat. I think similar, Haley. How do you approach your own Medicaid agency if you're interested? And first, Henry, Helen, I totally respect, and I think your decision is wise to prioritize. And then remember, it's a 5-year waiver. Maybe we didn't mention that earlier. And then you have another opportunity. And by the way, if you didn't hear me before, a waiver can be complex and it is hard work. And so, Roger, I'm thinking of a couple of points to your question. One is maybe engage legislature to prioritize it. And you know what? Your Medicaid agency is going to need a little bit of resource to figure it out. They just can't drop everything else they're doing and decide to do a waiver, especially if they don't have one. Not every state has an 1115 waiver, and so it can be complex to get that whole effort going. It will require governor, require financial office work. It'll require probably some legislative direction there. But if there is a waiver already underway in the state, there may be more receptivity to tucking this in, so to speak. I'll say though, our colleagues in California, who are of course a few months ahead of us here in Washington, this is the toughest implementation challenge from a Medicaid agency point of view, not to mention a jail or prison's point of view, that we've experienced probably since Medicaid expansion, now almost a decade ago. So it is a significant undertaking. But just a couple ideas there. I think legislative, maybe some prioritization, maybe some resources, and then especially if your Medicaid director already has a waiver underway, talk to them to see if this can be something they can prioritize too.
Thank you all. And I'd actually like to open that question for the other panelists as well. I think that's one of the main goals of this webinar series is starting those conversations between corrections and Medicaid. So if any of you have advice about how to bring this topic to, or this opportunity to a state Medicaid agency, find out whether they like milk chocolate, dark chocolate, if you remember sort of how to help start those conversations and those relationships.
I could maybe jump in here. I think that there's a question I saw in the chat about budget neutrality and how do you prove that. So an individual who's released from the correction system who say you have none of this in place, right? And they end up becoming eligible for Medicaid in some other fashion. If they're not connected to the system well, they show up in the emergency room, they end up being inpatients, they end up consuming healthcare at the most expensive places, delayed care, most expensive places. So I think in terms of you're trying to engage a conversation with a Medicaid director, there's an economic self-interest in terms of managing your Medicaid program to engage with the corrections. Because again, I think the way a Medicaid director looks at it, we have a longitudinal responsibility for an individual often who is been in an incarcerated situation, that they're probably going to take them a while to build an income where they're going to be able to leave Medicaid and maybe get into another opportunity for health insurance coverage through an employer or what have you. And that, you know, like, just like your mom would say, an ounce of prevention is worth a pound of cure. I think that's really the conversation to start the engagement.
One of the ways that it started for Washington State was just this discussion, and that was funding. Again, we were in a recession period of time when our conversation started back in 2011. And at Washington State Department of Corrections was paying 80% of billed charges for any offsite care that was occurring with our incarcerated population. We were able to, through these connections, and that was getting the state Medicaid director in a room and saying, what can we do? And this somewhat being forced by state legislature and the governor. We have saved the taxpayers of the state of Washington $553 million since we started this in 2012. And that's how that partnership, if you will, began, that moved right into this waiver process. So I guess my point is, don't think just inside the box of 1115 waiver. There are many other opportunities to engage with your state Medicaid directors and start having conversations with our justice involved individuals that can move the needle, whether it's within that waiver confine or external to it. There's a lot of efficiencies that can be found.
Well, and maybe just Rana emphasizing that, I think, so critical. So there's steps you can take before a waiver. Let's say your state is just clearly not ready for a waiver. And to sort of Roger's question, how can we really engage the state in the waiver? Well, I gave you some ideas, but let's say it's that clearly you're not ready. Legislature's not ready. The state Medicaid department doesn't have a waiver. They don't have resources to prioritize it. Why don't you look at starting with your suspension eligibility system? Why don't you look at starting with your billing system for your prisons already? And so again, Ron, I think two critical points of legislation. One, using the Medicaid billing system is not only the billing system, it is also the payment rate. The prisons should not be paying more than a Medicaid agency pays for the same services. And that's as simple as what Rana's mentioning here, and changing that rate and having a piece of law to say to the hospitals, particularly, you got to serve this population. I mean, let's face it, most of our hospitals are charitable institutions, community hospitals. And, you know, it is not unreasonable to ask them to have the same rate as the Medicaid agency. It could be a political hot potato, but that is what we're talking about here. And it is actually not and should not be too complex.
So Jason, I'm smiling this big, and Henry knows it, because in my previous capacity in corrections, we did just that. I learned in the early part of my career, we were paying some negotiated percentage of full bill charges. And so people who aren't in the insurance world, it's out of pocket, right? Why would people who are incarcerated in a corrections agency pay out of pocket full rate charges when we're serving a population of people whom, in the absence of where they are living, would be eligible potentially for Medicare and Medicaid and even pre-expansion. So part of what we did strategically, and these are good conversations, you know, the gateway to talking to your Medicaid director is to talk about the realities of the costs of healthcare and incarceration, and they're not getting any cheaper. And how do you pave that way? So you do have to advocate to change the law. And our law doesn't say the Medicaid rate, because we got them with the Medicare rate. And at the time, our Medicaid rates didn't open the door to healthcare, let's just say. And I think that will change in the future. But there's something else in corrections that I think is important to weave into this national conversation. Healthcare delivery services in corrections are not defined clearly. So depending on which state you're in and what that state's litigation effort or advocacy effort is, the base set of services are not prescribed. But we as individuals navigating our healthcare communities, our healthcare access is predicated on our insurance coverage and our ability to pay. So part of this discussion that is happening nationally and as part of this movement forward using the continuity of care coverage that Medicaid offers for those involved in the justices, let's all agree Medicaid is a base layer of healthcare delivery services in a correctional setting. And we hope that in the future, that set of services, albeit are robust and increasing, get better to help people stabilize their lives. And I don't want to lose sight of something that Jason said earlier too. We talk about substance use disorder and we talk about these things, but you did say some key things that are public health issues and very, very treatable. And that's hepatitis C and HIV. And we can eradicate those disease states or illnesses just through these relationships and ensuring continuity of care for all the sets of services that people need. And that is really our mission and discussion. And a Medicaid director should also appreciate that conversation. So if you can't get the door wide open, find your public health partner to open the door with you.
Thank you, Helen. I couldn't agree more. And by the way, I love Medicare rates too. If you can't get to Medicaid, Medicare's a great place to start. Perfect, perfect. Good work, New Hampshire. You know, I might just mention too, you mentioned the, where else you could start, right? For eligibility purposes, Medicaid can pay your Department of Corrections, your local jail services. So we can pay a staff person to help with eligibility. We can do that today. It's called the Medicaid Administrative Claiming Program, and that is already allowed. And Washington had the first in nation MAC program, MAC, Medicaid Administrative Claiming Program for that. So just another idea of where you could start.
Well, I love the practical advice. I feel like I could very happily spend another couple of hours with this group. There are a bunch of operational questions that came in about working with MCOs. So, stay tuned for part 3. I think there might be a little bit more, but for now, I'd like to bring the slides back, go through a couple of resources that I hope are going to hit home some of the ideas that we just heard our panelists talk about. So, first up, we have a poll, and there are resources after the poll. So stay tuned, stay. So what did you hear today that is going to inspire you into action? Like what are you going to do today? Now that you've heard this information, now that you've heard how Washington's approached it, New Hampshire's has approached it, we're hoping that there are a couple of practical things that you're going to do coming out of this webinar, and we'd love to know what those are. And just, so that you understand what the information goes to, it helps BJA understand what sort of training and technical assistance will be most helpful. If many of you say, I need more help reaching out to my state Medicaid agency, that can be a source of future training and technical assistance, or, depending on the different things you all select. So it's a poll with a purpose. Fantastic. Thank you all so much. We really appreciate this. Will be helpful information going forward. I do see a lot of folks saying that they're going to connect, and also a lot of interest in learning more. So let me help you start on that journey. Next slide, please. We heard today a lot about different ways of making connections to Medicaid for people in corrections. We wanted to make sure to not lose sight of the opportunity right now with Medicaid renewals. As many of you know, the legislation that was enacted during the pandemic, allowing people to keep their Medicaid coverage without having to reestablish their eligibility, is ended. And so it puts, with the end of the public health emergency, 3 years of eligibility redeterminations are happening at once, with each state using a different process. And this puts people at a risk of losing coverage if they don't reapply. So we have, and we'll put in the chat a couple of resources focused on Medicaid renewals. Local and state corrections facilities have a unique role here in ensuring that people who are leaving the facilities have health coverage. And this is another place where corrections can work with state Medicaid and local health authorities to ensure that people who are leaving have submit renewals if necessary. A couple of ideas that have already come up in that space are opportunities using the visitor rooms and other public spaces in facilities to provide Medicaid renewal information for families and visitors. Medicaid.gov has resources and posters in multiple languages. And we've also included some resources on the slides that are going to be sent out after the webinar. So in the continuing effort to ensure that the field is getting training, technical assistance, resources that are most helpful, I'd like you all to also stay tuned for an email that's going to come from us in the next couple of days that includes a survey to help in terms of prioritizing the development of future materials. These slides also include links to the first webinar back in July. I think Susan's definition or explanation of 11:15 within like 3 minutes was excellent. The webinar in July helps really lay a foundation for what the demonstration waivers can be, excuse me, what's included in the state Medicaid director letter and the opportunities for corrections. And we're also sending around the links to the direct resources, including the applications submitted by both of our states who were featured today. I'd love to have you join me in thanking our panelists. It was really fantastic to hear from you all from both the state corrections and the state Medicaid perspective about how you came together, the history of the relationships, how you've been thinking about this particular opportunity, but also how you've been thinking beyond the 11:15 opportunity for other ways to create coverage opportunities for people who are incarcerated and leaving this incarceration. So thank you, a huge thank you to our panelists, to our hosts at BJA, and to the team at NTAC and the CSG Justice Center who helped put the webinar together. There's a whole group of people behind the scenes who are making this happen, and we're very grateful for them. Thank you all for being here, for taking time out of your day to attend yet another webinar. We all hope that you got information that will be practical and useful for you in the important work that you do, including information here on how to stay in touch with us. So you saw Meg's email, you saw my email. You can also connect with BJA through Twitter, Facebook, and YouTube, as well as by visiting the BJA website. Thank you all so much for your attention today and for the work. Thank you for the work that you do, and we look forward to staying in touch. Thank you.
Everyone.
Thank you.